All right, everyone. If you are in the room and here for the webinar tonight, it is Dr. ICW. You're in the right place here. We have over 100 people signed up for this. So I'm going to give a few seconds for people to get logged in here. For this to be live and polling, we do have polls. If you look at your screen there, you can go, I think it's on the right-hand side, you'll see where it's polls. We're going to be launching some polls throughout here. COPE is nice enough to allow us to do these live webinar presentations. There's some rules we got to follow. So you being logged on and with unique passwords, it allows us to track all that. And when you log off, so let's just try a polling question here before I go through some housekeeping. I'm going to see if I can get this to launch here. And the first polling question, it's just in a sense practice, is due to COVID, what's your practice situation? Are you closed, open for emergencies and urgencies, open with a reduced schedule, full-time, and pretty much back to normal? And I see the people are got this all figured out. I see them rolling in. And it's good to see. We've been doing webinars now probably since March, and you know, closed is 2% right now. Closed used to be a really high number. And we see open for emergencies, still maybe 1 or 2 people, that's 1%. But open with a reduced schedule is about 52%, and full-time is 41%. And I'm happy to see that happening out there, as optometry is very important for this healthcare system. So that's awesome. I won't do the next polling question. Looks like a lot of people have gotten in here. I'll do some housekeeping. I'll introduce our speaker. And then, Joe, I'm going to go live. I have a couple people, or I'm going to go mute and turn my camera off. I got a few people that need help getting in.
Alrighty.
So housekeeping, that's out here. We talked about the polling questions. This course is being recorded. You will get a replay. In about 14 hours, you'll get a replay. You'll have to use your unique password to watch it. However, I will download this. We do have a YouTube channel, and we will house them there. We have people asking us, can I go back and rewatch these webinars? So we have a YouTube channel, Optometric Education Consultants, pretty straightforward if you want to go there. There's all the videos are right there. A survey will be sent in about an hour. So just please do that because of the regulatory process that's out there. The best thing that you can do right now is decrease the competition with your bandwidth at home. Webinar Jams goes to a cloud, and then it goes to you. So it's, you know, if there's any competing, we have doorbells and refrigerators and scales that all work on the Wi-Fi. You got children doing Xbox and spouses watching and streaming movies and maybe playing Xbox. That all competes, and that will make for an issue doing this webinar. There is a chat section, so please, I'll monitor that for Dr. Saka. For if you have any questions, that's where you put the questions, and I can read them to Joe. Vanessa is our conference coordinator, and she will send all this information to Arbo. We'll get that done probably by the end of the week. It takes Arbo about a week to turn this around right now because Arbo is so busy with webinars. We will also mail you a certificate of attendance within a week. Please fill out that survey. So with that being said, let me just introduce you to a good friend, a partner of Optometric Education Consultant, Dr. Saka here. Joe is a professor, was a professor. I'm not sure how that goes. Joe, I know you're a professor, and now that you're not working at Nova after being there for 28 years, I guess still a professor, just working at a different practice. And while Joe was there, he was the Chief of Advanced Care Services, Director of Glaucoma Service, and the Chair of Department of Optometric Services. Joe is a founding member of the Optometric Glaucoma Society and Optometric Retina Society. He's the current Chair of Neuro-Ophthalmic Disorders in Optometry for the American Academy. But Joe's a gifted speaker, but he's also a gifted writer, probably hundreds, if not thousands of articles out there. I wrote an article, I gave it to Joe, and he handed it back to me and made it look beautiful. So hopefully you get to read some of his stuff. Joe is a well-known national and international lecturer, and he's currently working for the Center of Sight. Joe, it's all yours, my friend. Looking forward to having this presentation tonight.
All right, thanks, Greg. I want to welcome everybody. And a special welcome to, I think, a number of NOVA third-year students, and invited them. I think a number of people have signed up. So please say hi in the chat so I know who's here. But welcome. See, I'm technically still your professor. It's almost like I never left. I see something in the chat from Richard. Are we going to do more of these after August 19th? The answer is yes. We will be doing these periodically, probably once a week or something very similar to that throughout the end of the year. So with that, I am going to share my screen. And we're going to get started. Oh, this is not working. That didn't work. Hold on for 1 second. Let me just get this set up. Just give me one hot little second. I think we should be good. Hopefully, Greg, we're doing well, that we can see everything we need to. All right, our talk tonight is Dr. I.C. Double, Managing Cranial Nerve Palsies. I am on the advisory board of a number of companies such as Novartis, Allergan, Ocular Therapeutics, Glaukos, Bausch & Lomb, and Zeiss. Got no financial interest in a product, disease, or instrumentation mentioned, and I receive no royalties when patients complain of double vision.
Joe, and just so you know, all I'm seeing right now, and I think the attendees are just seeing your list of all your talks and PowerPoint presentations.
All right. Looks like I have to back this up. Hold on for 1 second. Sorry about that, guys. We're having a little technical difficulty. Okay. Are you seeing it now, Greg?
Nope, I just see you.
Okay.
So when you click on the share the screen, there's an application button. Maybe click on there, and that's where your PowerPoint is. Application window.
Mm-hmm. Are we up now?
No, you're just getting...
Yeah, we never really had this problem before. Hold on 1 second.
If you're in PowerPoint mode, that might be the issue. Then get out of PowerPoint mode, let it find it, and then go into PowerPoint mode.
Okay. Are we up yet, Greg?
Nope, I just see. So when you click on the share, do you see where it says entire screen and the next one over says application window? If you click on application window, is your PowerPoint in there?
I'm going to turn this off. Application. Now it finally came up. It was not up until now. Are we good?
Yeah, now if you click on PowerPoint, you'll go to it.
All right, we're good?
Now you're good. Sorry,
okay,
everyone.
No worries, that tab did not come up until just now. All right. So we're going to talk some ocular motility problems. We've got the non-paralytic strabismus, your garden variety diplopia. We're not going to talk about that. Muscle restriction, it can always be thyroid disease, it can be muscle disease, it can be neuromuscular junction disease from myasthenia. We're not going to talk about that. Really what I'm going to talk about is the paralytic strabismus, cranial nerves 3, 4, and 6 palsy. And we have a lot of anatomic territory here. And we have cranial nerves that arise in the dorsal mesencephalon or the pons, 3, 4, and 6. They're going to have a circuitous route getting to ultimately the muscles that they're going to innervate. And when there is a disruption, we can have a paralytic strabismus. Now, there are several questions we have to ask and answer. Is it real? Is the diplopia present monocularly? Is it side by side or up and down? Does it get worse if it look left or right? And is it greater at distance or near? And once you answer all these 5 questions, you can figure out what muscle is involved. Once you know what muscle is involved, you know what nerve is involved. Once you know what nerve is involved, you look at the patient, you look at their age, look at their profile, the medical history, and you can start to ascertain what the potential causes are. One of the first things I do is when a patient complains of double vision, the first thing I try to do is I just try to talk them out of it. It's not really double, is it? Maybe your bifocals are off a little bit, or you got some astigmatism. But when they really complain of true double vision, what we're going to do is we're going to ask, is it in one eye or both eyes? We have to alternate covering their eyes. If they cover an eye and diplopia is still there, it's monocular. It is not neurologic. You're dealing with something else. You're dealing with keratoconus, astigmatism, uncorrected refractive error, cataract. When I first developed a cataract in my right eye, not only did I see diplopia, I saw triplopia. I would actually see 3 images from a cataract. Ocular surface disease, put the pinhole in. That's going to cure monocular diplopia. And you know that it's a refractive issue, but monocular double vision is never neurogenic. Is it side by side or up and down? Of course, we don't use the term horizontal or vertical for a patient. It can get too confusing. Is it side by side or up and down? Horizontal double vision is going to be 1 of 4 muscles, the 2 medial recti or the 2 lateral recti. Vertical double vision, it's potentially 8 muscles, the superior rectus, inferior oblique, superior oblique, inferior rectus on the right and left side. Does it get worse in a particular direction of gaze, looking left or looking right? Horizontal double vision to the right is going to be 1 or 2 muscles, the left medial rectus or the right lateral rectus being 3 or 6. So you know the muscle, you know the nerve. Vertical to the left is going to be 1 or 4 muscles, the inferior oblique or superior oblique on the right side, or superior rectus, inferior rectus on the other side, narrowing down to a divisional third, which really doesn't happen, or a 4th. And is it greatest at distance or near? Horizontal double vision at near is 1 of the 2 medial recti. Horizontal double vision greater at distance is 1 of the 2 lateral recti. And vertical double vision worse at near is going to be 1 of the 2 superior oblique muscles. So by asking these questions, we figure out what muscle is involved. We figure out what muscle is involved. We know what nerve is involved. Once we know what nerve is involved, we look at the patient profile and other characteristics. We start to narrow down what it could be. So is it real? If we determine that it's real, what is the onset? Things that happen acutely are often vasculopathic, or they could be aneurysmal. But vasculopathic is really the most common cause, and these usually have about a 3-month duration, and they're going to recover virtually fully, probably within that time. What is the course? Is it getting better or worse? Something getting progressively worse mitigates against an ischemic cause. Something that happened suddenly and is now improving over time mitigates toward an ischemic cause. And what else is new? And we have to talk to the patient and get them to offer up what is happening at the same time. There's a term that I coined called spatial temporality. What happens in terms of time or space? Question is, what were you doing? What is different since you started seeing double? It's an incredibly important question. You ask this question, it will help narrow things down. What else happened about the time you saw double? And is a double vision from an isolated nerve and muscle? Or are there other travelers on this route? What does a pupil look like? What is a lid positioning? Do they have paresthesias? Do they have hemiparesis? Are there are there multiple neuropathies? These are all things we have to consider in terms of the presentation. Well, it is an optometry conference, so which is better, one or two? Here are two patients with ostensibly the same diagnosis. Better one, better two. Better one, better two. Can I see it again? He's a 63-year-old Indian male who's a long-standing glaucoma patient of mine in the glaucoma service. I was his eye doctor for many years. He developed a sudden onset of orbital pain of 3 days duration. It started on a Friday, got worse on a Saturday, was unbearable on a Sunday, and he waits until Monday to come in to see me because I'm his eye doctor. He's diabetic with hypertension, pretty well controlled. He's on Coumadin, and he has a pacemaker, two very important parts of the story. He has no vision change. He's not complaining about double vision. He's complaining about pain, and he looks like this. And what we can see is there's a 3/4 ptosis in the right eye. He's never looked like this before. So he's got a partial ptosis, and we can see underneath the eye is a little bit down and out. So when we lift his eyelid, he cannot look up, he cannot look down, he can AB duct, he can look to the right, but he cannot AD duct at all. So he has depression of elevation, adduction, depression. The next thing we have to do is look at what is his pupil. And it may be hard to see, he had a 2 millimeter responsive pupil in this eye, a 5 millimeter totally unreactive pupil in this eye. I think it's pretty clear. This is something we all learn in third grade of optometry school. He's got compression to the third nerve. It's a third nerve palsy. It's a partial palsy because we don't have a complete ptosis. It's pupil involved. That means compression. And when things happen suddenly compressively, we have to consider that first and foremost, this is one of the true emergencies in eye care, in that he has an aneurysmal third nerve palsy. So he's got a pupil-involved third nerve palsy of 3 days duration at least. Most likely cause is an intracranial aneurysm. Specifically, it is most likely the posterior communicating artery has developed an aneurysm in subarachnoid space. And I can tell you right now, this was not a long exam. This whole exam took maybe 10 minutes. I checked his vision, checked his pupil, checked his motility, took the photographs, and educated the patient and his wife. And I offered to call an ambulance. And this is probably one of the most appropriate things to do. A person who goes to the emergency room, and this is something that goes right to the emergency room. People who walk in ambulatory tend to be treated differently than if they come in on a gurney. I offered an ambulance. He and his wife declined, but she said she would take him she said she'd take him to the emergency room. And I sent a note, right third nerve palsy, pupil involved, suspect posterior communicating artery aneurysm. Patient needs to see neurosurgery stat. And as I was writing this out and educating the patient and his wife, I could see she was getting a little anxious. And I knew the question was coming that was going to come. She nervously asked, how much is this all going to cost? We don't have insurance. And my response was, it doesn't matter how much it costs. He's going to die. If he goes home, he lays down, he's going to become comatose, and it'll be too late. And I'm happy to say within 45 minutes of saying that, I got a call on my cell phone. He was already in a CT scanner. Not that he got there, he's already in the scanner. He was hospitalized for 23 days, underwent 2 neurosurgical intervention where they packed the aneurysm with coils, and he survived. He looks like, this is what he looks like now. Over time, his ptosis has improved greatly, but his motility deficit did not change. He can't look up, can't look down, he can't adduct, and his pupil is still fixed and dilated. I can tell you if he walked into anybody's office without telling the story, they'd panic. It's a third nerve palsy. He has been treated. Now, as he looks down, we can see he's got what's called a pseudo-von Graefe sign. This is secondary aberrant regeneration. This is expected after trauma, tumor, or aneurysm. This is expected. But it never happens in diabetes. As the nerve starts to regenerate, it misconnects. Fibers that should go to the medial rectus go to the levator, and fibers that should go to the inferior rectus also go to the levator. So when he looks down, inferior rectus is trying to work, it's actually pulling the eyelid up. This will never happen from ischemia. This is seen from ischemia. It's not the cause. So clinical picture of a third nerve palsy is an eye that's down and out with a ptosis. It's an adduction elevation depression deficit, and the patients may be isochoric or anesochoric. Here's an example of another patient I've been seeing at the university. He was a horribly controlled diabetic. I think his blood sugar was in the 300s. I actually saw him on follow-up. And I think his A1C was around 11. And I didn't get involved until the follow-up, but I do know one of the faculty tried to order imaging for this patient through the internist. And I suspect because I saw the report, and it did make me shudder a little bit. I'm sure the person who was ordering a test through the internist overwhelmed the internist with information and probably said somewhere in there, but this might be due to diabetes and ischemia. So when they ordered the MRI, they ordered it for brain ischemia, and that is exactly the wrong thing to do. The best neuroradiologists in the world can't help us if we don't order the scan, order the right scan, and tell them what to look for. Looking for brain ischemia could easily miss an aneurysm because they're not looking for it. Fortunately, this was ischemic and he did recover. So what happens is it's this area here where the nerve comes to the interpeduncular fossa. It runs parallel to this vessel called the posterior communicating artery, and it's very close and it is very prone to aneurysm from that vessel. Greg, can you launch polling question number 1 for me, please? I think Greg is having a mental pina colada.
Yeah, I'm having a mental pina colada for sure, but it's not here, Joe. I'm sorry. They didn't make it over, so.
All right, no worries.
I'll research that, keep moving on. I'll see if I can fix that in the background.
No worries. Well, talking about third nerve anatomy, because the vessel is running close to the nerve, the posterior communicating artery, it is vulnerable to compression from an aneurysm in the subarachnoid area. It's mostly the posterior communicating artery. It can be at the junction of the posterior communicating internal carotid artery, or it can be at the tip of the basilar artery. Now, the pupil and motor fibers travel with the third nerve, and they coat the third nerve. So as it coats the third nerve, anything touching it from the outside can potentially affect the pupil as well as the motility and the lid. But if there is an ischemic event, the core of the nerve can be infarcted, but the pupil and motor fibers, for their external position, they're getting a rich watershed and anastomotic communication blood flow. They're generally going to be preserved. And that's why the power of the pupil we have to look at. Now, I want to caution you. There's not a situation where an aneurysm will compress the pupil and motor fibers and not affect the lid and the motility. An isolated, dilated pupil is not an aneurysm. Now, it's also anatomically important how close the artery is to the nerve. If in an individual there's a fairly substantial distance between the two, it's going to take a large aneurysm to cause compression. Here's a caveat. If the vessel and the nerve are close together in an individual, a very small aneurysm can cause compression, and it can be missed on imaging. So if you have a high suspicion of aneurysm, it's important that we get this run down properly and the patient gets the proper care. Even if the imaging says it's not there, it probably is. So a dilated, poorly reactive pupil, it means compression. Pain can be anything. Pain is only helpful if it's not there. Aneurysms are always painful. They touch pain-sensitive structures. They start to leak. You have meningeal irritation. Ischemic vascular palsies are painful 90% of the time. So pain is only helpful if it's not there. You can't qualify the pain. You can't say an aneurysm is going to have a boring, thunderclap, hemicranial pain. No, it's not true. Case in point, Temple University football player develops a third nerve palsy with a little bit of headache, aneurysm. Little old lady, worst headache of her life, diabetes. And a spared pupil does not always rule out an aneurysm, especially when they're incomplete. These partial nerve palsies, as they're developing, it usually means there's an aneurysm that's expanding and causing a dynamic phenomenon. And you can have some people where they have third nerve palsy from aneurysm. They're usually incomplete palsies. The pupil may initially be normal, but they still have an aneurysm. And this is what I mean here, a person with a partial palsy, where there's a little bit of ptosis and a little bit of motility deficit. Now, these don't happen within seconds. These things will develop over time as that vessel balloons out. So the partial palsies are also very problematic because it's likely a nascent and developing aneurysm. But a pupil-involved third nerve palsy is a posterior communicating artery aneurysm until proven otherwise, and an incomplete palsy is also an aneurysm until proven otherwise, regardless of the pupil. Now, 30% of third nerve palsies are caused by aneurysm. I'm going to qualify this. I want you to come away from this and thinking there's a 1 in 3 chance only that it's an aneurysm. I'm not saying that. There are some patients with certain characteristics, you look at them, you realize there's less than 5% chance of this being caused by an aneurysm. And another person you can look at and say there's a 95% chance this is caused by an aneurysm. So it is very patient-specific, but out of all the causes, a third are aneurysmal. Vasculopathic thirds will resolve in time, within 90 days, probably without any sort of deficit, but aneurysms will rupture in time. Now, why is this so important? 20% of these patients will die within 48 hours from rupture of the aneurysm. That's a very sobering statistic. They develop a third nerve palsy from an aneurysm, 20% are dead in 48 hours. Half the patients overall will die. This is a true emergency. Many patients never make it to the hospital, and that's why I like to call ambulance, because if they rupture, they're going to be in a situation where they can be stabilized. Now, how do we treat these, or how are these treated? They can be treated endovascularly, where a interventional neuroradiologist will go through the catheter through the femoral artery or the radial artery in the back of the wrist. They'll go up here. If they can, they'll put a stent in the vessel and squeeze these coils in like toothpaste, filling it up. And it really makes it almost impossible or very difficult for blood to get in there. If blood can't get in there, it's not going to rupture. The other option is an aneurysm clip, where they actually do a craniotomy, open up the skull, and they actually put a clip on the aneurysm like a clip on a bag of potato chips. Now, interestingly, both procedures are equally effective, and Both are pretty straightforward and relatively simple for a skilled neurosurgeon. The only difference is an aneurysm clip involves a craniotomy for the patient. Now, if there's a high suspicion of an aneurysm in the hospital, they're going to get digital subtraction angiography. But non-invasive CT and CT angiography is actually the preferred non-invasive imaging for third nerve palsy. CT will show the subarachnoid hemorrhage, and CT angiography will reconstruct that vascular system very well to see the aneurysm. Now, CTA does require contrast. If they're renally impaired, MRI and MRA is better. CTA is better than MRI when a patient can't get an MRI if they have a pacemaker like the patient did or they're claustrophobic. And MRI doesn't really take, MRA doesn't take very much time to add to a scan, and MRI can be superior if it's not an aneurysm or something like a tumor or inflammation. And these are some examples here of imaging. We can actually see the vascular system very well being recreated, and they can find the aneurysms. Now, I've always recommended, if you're going to order this testing yourself, always go for spend the extra money and get the ones that actually come with the arrows, because they're a whole lot easier to read. Now, here's a different patient, different prognosis. 63-year-old female, diabetic and hypertensive, both poorly controlled, and she has a sudden onset of retroorbital pain. Not double vision, not I can't lift my eyelid, it's my head hurts. She has a complete ptosis. We lift her up, she can't look up, she can't look down. She can AB duct, she cannot AD duct. So she's older, she's got a complete third nerve palsy, pupils are symmetrical and reactive, she's got vasculogenic risk factors. Which is better, one or two? She resolved over several weeks without complications. He was hospitalized 23 days, 2 neurosurgical procedures, but at least he did live. Always suspect the worst. I was doing this talk somewhere out west, maybe Montana or Wyoming, and what I think is a very brave optometrist in the audience got up and shared a story where they had a patient with a third nerve palsy in their practice. I don't know anything about the pupil. They referred the patient to an ophthalmologist the next day. Unfortunately, the patient died from a subarachnoid hemorrhage before in the consult because it was aneurysmal. These go to the hospital. There's no question about it. Now, does the presence of vasculopathic risk factors help? If you have arteriosclerotic risk factors in an older person, that does kind of point you toward a microvascular etiology, but it doesn't rule out an aneurysm, because hypertension, diabetes, hypercholesterolemia, atherosclerosis, they're all very common. They don't protect against an aneurysm. So the answer is no. But it makes me very nervous when they're not there. Does the acuteness of the presentation help? Well, kind of a yes and no. Aneurysm expansion is usually pretty rapid, but chronic and slowly evolving cases are reported in the literature. So acute is worrisome. Chronic and improving is less worrisome. Resolved without recurrence is very good. So what is our threat assessment? An isolated dilated pupil is no risk of an aneurysm. A complete third nerve palsy with a normal pupil is a low risk of an aneurysm. A partial third nerve palsy with a normal pupil is a high risk of an aneurysm. And a pupil involved third is an emergency. So ambulatory patients with isolated fixed dilated pupils, unresponsive to light or near, have an iris issue, or they have a ganglionic issue, they have a tonic pupil, or a pharmacologic misadventure. Angiography is too high a risk. There's no imaging needed for an isolated dilated pupil. You may remember David Bowie. He's got an isolated dilated pupil from trauma. We always had the saying in neuro-ophthalmic disease, don't neuroimage David Bowie, because he doesn't have an aneurysm. You're never out of the woods, though. Patient developed a third nerve palsy from an aneurysm. Now, of course, I told you the treatment choices, an aneurysm clip or those endovascular coils. And he was successfully treated with a craniotomy and an aneurysm clip. But what I didn't tell you is all those coils were inert and MRI safe. But at that time, not all aneurysm clips were MRI safe. A radiologic tech didn't verify what type of clip had been used. Undergoes a follow-up MRI with a non-approved clip in a major Texas medical center. It did move during the MRI. The patient had a fatal hemorrhage during the procedure. He died in the tube. So he survived the disease, but he was killed by the follow-up. Greg, do we get any polling questions yet? Do we get those? Are they launching?
It is launched.
All right.
I was able to resolve it. Polling question number 2 says, which of the following does not get sent to an emergency room? Isolated dilated pupil, pupil involved third nerve palsy, pupil spared partial third nerve palsy.
And hoping this will be an easy one. And Greg, what are our results?
Well, they're rolling in here. Isolated dilated pupil is 93%, and we got 2% and 2% for pupil involved third nerve palsy and pupil spared palsy. So the winner is isolated dilated pupil.
Yep, you need to look for tonicity of the pupil. You need to elicit trauma or some sort of pharmacologic misadventure, but it is not aneurysm. That's a lot of stuff to remember. If you can't remember all that, I want you to remember my ode to a third nerve. When the eye is down and out with ptosis, you better hope for meiosis. If the palsy is total with pupil sparing, in an oldie, it's vascular, not too daring. A partial palsy calls for double duty because there's probably an aneurysm going through puberty. But if the pupil is dilated and the aneurysm is violated, no time for deferral and no time for referral. Send to the ER without debate. Remember, 20% will die within the first 48. If you can remember that, you're going to be fine. Next is a 35-year-old male who's referred me by his GP for emergency evaluation due to vertical double vision for the past 2 days. 20/20 each eye, no afferent defect, perimetry is normal. He had a right hyperdeviation worse on left gaze and right head tilt. Medical history is normal, but he had the worst case of sinusitis he had ever had about a week before he developed double vision. So he was diagnosed with a right fourth nerve palsy. So when suspecting fourth nerve palsy, we have the 3 cardinal questions to ask. Which eye is higher in primary gaze? Does the hyperdeviation get worse in right or left gaze? And does it get worse a right or left head tilt? The motility that we have here is a hyperdeviation in primary gaze, which is greater in opposite gaze than ipsilateral head tilt. And if you can say that, you're done. You know what you're dealing with. This is such a common cause of vertical double vision that vertical diplopia is a fourth nerve palsy until proven otherwise. Now, if it's new and you can't say that it's a fourth nerve palsy, then it's probably a skew deviation and you're dealing with midbrain disease. And how do you tell? That's a vertical diplopia that doesn't mask out to a fourth nerve palsy. And here's what we do. Lay the patient back. Look at their motility. Lay the patient back. If it's a fourth nerve palsy, the motility doesn't change when they're laying on their back. If it's a skew deviation, the motility will improve by close to 50%. So you know if you got a fourth nerve palsy or if you got midbrain disease. It's very common in kids, often traumatic, many times congenital. This young woman right here had a very, very mild auto accident. Barely a fender bender. I think both cars drove away. And next morning she has a hyperdeviation. She has got a fourth nerve palsy. Did not hit her head, did not get injured in any way, but the shock waves was enough. And this one, this youngster, we have a double fourth. You see, she has a left fourth, and Dolly has a right fourth. So I call this a double fourth. Now, because this exits the midbrain and goes around the brainstem, it's got the longest course and it's the most exposed. It is going, it is going to go through around the tentorium. It's going to go through the cavernous sinus, the superior orbital fissure, and because it's so exposed, it's most prone to trauma. You don't have to have head trauma; it does help. You don't have to have eye trauma. Someone who falls, ice skating, falls off a horse. The shock waves can be enough to cause this to happen. Now, long-standing fourth nerve palsies can actually present with double vision because they just decompensate. They get tired. And we can look at old photos for a head tilt. I used to say Facebook tomography. With everybody doing selfies, that's not such a good idea. But here's the patient with the fourth, and she's sitting in the chair. She's got that constant head cock like that. Remember the rule of 40, 30, 20, 10. 40% are traumatic, 30% are idiopathic, 20% are ischemic vascular, and only 10 are bad things, like CNS tumors or demyelinating disease. So there's a 90% chance this is a relatively benign type of situation. And one thing you can do is test vertical vergences. They've been working so hard to keep their eyes fused. It's like somebody working out with weights. They develop a certain strength. The vertical vergences are very impressive. So if they have that, it means they've been holding their eyes together for a very long time. Now, isolated non-traumatic fourth nerve palsies, we have to look for ischemic diseases, but understand non-ischemic causes are pretty rare. Look for signs of long-standing decompensation. Look at the vertical vergences and look at the old photographs. Now, going back to a 35-year-old with a new onset fourth nerve palsy and vertical double vision, what are possible etiologies? Myasthenia gravis, multiple sclerosis. We have to think of younger people. Ischemia, not common. Infectious diseases, syphilis, Lyme, yes. Race, inflammatory disease. But again, spatial temporality. What happened when you had the double vision? He had the worst sinusitis of his life. This is erosion of inflammation from the adjacent sinus. What was his outcome? When his sinusitis was treated with steroids and antibiotics, his double vision disappeared. Greg, do we got a polling question we can put up?
We certainly do, Dr. Salka, and I'll read it to the audience here. It says, what is the most common cause of a fourth nerve palsy? Trauma, tumor, congenital, or idiopathic? We have responses rolling in here. Idiopathic being 2%. I'll start at the bottom. Congenital being 5%. Tumor has moved down to 0, had a few responses. And it looks like the audience is nailing it, Joe. They're about 84, 85% saying trauma. So
if you think that between idiopathic and traumatic, that's 70% of cases, you realize you're dealing with something that is not usually terribly threatening.
Hey, Joe, well, right before you go to your ode here, I'm going to, so I don't forget, because I do that from time to time, I'm going to share the handout now. So for those that are on the webinar here, under files, it will just say tonight's handout. These will be a PDF of the handout for tonight for your reference. And then on top of that, again, we will put this to our YouTube channel eventually, and then you will get a replay in 14 hours. It's all yours, Joe.
All right. Well, there's a lot of stuff that we went through quickly, so I want you to help you out with my ode to vertical diplopia. When your patient sees double up and down, it's rarely a cause to frown. Look for a tilt and prove it's old, and remember, vertical vergences will be bold. It's a fourth until proven otherwise. Trauma, congenital, and idiopathic, you should surmise. But if it's a fourth, if it's not a fourth and it's new, Laying back, it's probably askew. If you can remember that, it's all you need for fourth nerve palsy. And finally, he's a 37-year-old white male who has a sudden onset of painful horizontal double vision for 6 days, worse at distance and right gaze. Now, his medical history was reportedly normal. He went to an ER where they shotgunned him, so to speak. He got a CBC and a non-contrast enhanced CAT scan, which were both reportedly normal. Now, he was a pack-a-day smoker and recovering alcoholic. Didn't really look, he was quite overweight, not very healthy. 20/20 in each eye. He had a right abduction deficit. Forced suction test was negative. I can move the eye out into the paretic field of gaze. Pupils were normal. Vision was good. Blood pressure elevated 144/102. Diagnosis, presumptive vasculogenic sixth nerve palsy, secondary to undiagnosed hypertension. I don't love a CT scan here, but he did have it. It was normal. Maybe by chance that it was accurate. But I chose not to image him at this time because of the true unilateral nature of this and some risk factors. Told him to wear a patch during his diplopic period. Within 12 weeks, he was back to normal, but I did send him to a primary care physician for a physical and hypertensive treatment. So the hallmark sign of horizontal double sixth nerve palsy is horizontal double vision, greater distance with an abduction deficit. And I can't stress to you enough, when you're looking for this, test them at distance. Don't have them look at your nose. Don't do your cover test. When they're converging, you'll miss it subtle. Have them look at the end of the eye chart and then do your alternate cover test, right and left gaze. If you have them converge, you could miss it. And these are two patients who have right sixth nerve palsies. So make sure you're checking at distance. And this is the one where I'll actually do a forced duction test just to make sure we don't have thyroid disease or muscle entrap or muscle infiltration. I'll put some apathetic into the eye, take a cotton-tipped applicator, put it right where you see. If I can easily push it over into that paretic field, I know that it's neurologic, and that eyeball just slid right on over. Now, sometimes this can be a sign of increased intracranial pressure. The sixth nerve comes out of the pons. It climbs up over the clivus to go by the petrix apex of the temporal bone. So if there's increased intracranial pressure, the brainstem will herniate down through foramen magnum and actually stretch it. So disc edema with unilateral or bilateral sixth nerve palsy is indicative of increased intracranial pressure. In patients who have pseudotumor, sixth nerve palsy is very common comorbidity. Now, managing sixth nerve, each case of sixth nerve palsy should be classified as traumatic or non-traumatic. And one thing I want to stress to you right now, fourth nerve palsy, you don't have to have a lot of trauma. But sixth nerve and third nerve, you need a lot of trauma. It's not a little bump. The last traumatic sixth nerve that I recall encountering was at the university. A 15-year-old had been assaulted, was hit with a cinder block, and actually had a piece of cinder block with an abscess still in the back of his skull. It's got to be a lot of trauma. Now, non-traumatic cases should be divided. Is it isolated, just a sixth nerve palsy? Or is there something else going on? Is it non-isolated? Is there a Horner syndrome? Is there a fourth? Is there a hemiparesis? Is there an ataxic gait? These are all things we have to consider. And then we should ascribe it to one of three groups: children, young adults, and older adults. And what are my cutoffs? Children, under puberty. Young adults, puberty to about age 50. Older adults, over 50. Now, sixth nerve palsy in older adults, if it's isolated, it's usually not bad. It's usually vascular disease. It's pretty common, and it will resolve within about 3 months, usually within about 6 weeks. But always consider giant cell in patients over the age of 60, so do that history. In children, it may be bad. Now, presumptively, viral illnesses can cause this, but there's about a 50% chance you were dealing with a malignant disease called pontine glioma. 6-nerve paresis in a child goes to a pediatric neurologist. Young adults, usually bad. Vascular disease or idiopathic is not really common, but usually they don't have isolated cysts. They usually have complicated cysts. They've got a 6-nerve palsy with a hemiparesis or a Horner syndrome or a facial paresis or something else. And cerebrovascular accidents of the pons, aneurysm of the cavernous sinus, or tumors can really account for, and also in younger people, multiple sclerosis. Here is a very important clinical pearl. I'm not sure it's in the notes anywhere. I'm going to give it to you right now. 2 places a tumor can hide and cause a 6-nerve palsy: the base of the pons and the cavernous sinus. Always remember that. A former resident of mine contacted me about a patient. Patient had a 6-nerve palsy. Patient also had been treated for a salivary gland cancer. Never diagnosed ischemic anything in a patient with a history of cancer. I told her, look in the pons and the cavernous sinus, and yes, there is metastasis to the cavernous sinus. So here's my flow sheet. 6-nerve palsy. If it's not isolated, there's something else going on, you have to evaluate them, either yourself or with neurology. If it's isolated in an older adult, we can usually monitor them without imaging. If it's a child, isolated, I want them to see a pediatric neurologist. And if they're a young adult, isolated, monitor them very carefully, follow it closely. I would neuroimage that one. And if you want to refer to neurology, you're not wrong. So in older adults, isolated 6-nerve palsy in a patient with a history of diabetes or hypertension, neuroimaging can be deferred unless the palsy progresses, doesn't get better over 3 months, or other complications develop. Here's something to remember. Ischemic palsies will progress over several days. It may progress over a week. It may be no better in 2 weeks. But it won't get worse over 2 weeks. That's not ischemic. And if you feel uncomfortable, always remember, if you think something is ischemic, a 6-nerve palsy is ischemic, and you're wrong, you're not really going to hurt the patient because there's nothing that's going to kill them right away. So you're not going to hurt the patient if you judge incorrectly in this case. Greg? Got a polling question?
I certainly do. It's polling question number 4 here says, isolated 6-nerve palsy in an adult should always be neuroimaged. 2 answers: agree, disagree.
I'm kind of curious how this one comes out myself.
Okay. Isolated 6-nerve palsy in an adult should always be neuroimaged. Agree or disagree? Give it another second or two here, Doc, and I'll end the poll. I'll look at the chats to see if any questions are rolling in. Please leave your questions in the chat box for Dr. Salka. Okay, I'm going to end the poll. And Joey came out disagree 80% and 20% say agree.
And interestingly, and this is almost a loaded question, or neuro-ophthalmologists can't even agree on this one. You know, this is something that gets argued at neuro-ophthalmology meetings all the time, so they can't even agree. So if you know, there is no right or wrong answer in that one. Some people believe they should all be neuroimaged. Other people feel okay just waiting. That's a lot of stuff to remember, so I'm going to leave you with my ode to a 6th. When the double is side by side and abduction does not abide, prove it's a 6 with a forced suction test. Eliminate muscle, thyroid, and all the rest. In kids and a young adult, it's a worry. Get a scan, you better hurry. But in an oldie, you're practically free. Prescribe a patch and check to say it's better in 3. And if you can remember that, that's about all you need for 6th nerve palsy. I'm just going to give you a few last things here. We're going to wrap it up. My little cheat sheet. Horizontal double vision is virtually going to be always a 6th nerve palsy. Medial rectus palsies don't happen. You're dealing with an internuclear ophthalmoplegia, you're dealing with myasthenia gravis, you're dealing with muscle entrapment, but you don't get medial rectus palsies. Nearly all 3rd nerve palsy will get some sort of imaging today. And vertical diplopia is a 4th nerve palsy, and if it isn't, it's a skew deviation. Nobody does forced suction testing for vertical double vision. It's too complicated. And a 3rd nerve palsy just doesn't cause vertical diplopia. Now I'm going to jump ahead just a wee little bit and come to my final rules. Sudden onset palsies are typically vasculopathic, but could be something else. Check the lipids, blood sugar, blood pressure, get an internist involved. Follow up in 2 to 6 weeks looking for improvement. Do we image isolated complete palsies? Yeah, if they're under the age of 50. Over the age of 50, it's debatable. If it's not isolated, there's other things neurologically going on, they need a full evaluation, but arteriosclerotic palsies are the most common. And here is one of the most important rules. This is actually mine. I actually came up with this. I've lived by this, and it has not let me down. Always remember, ischemic palsies can get worse over the course of a week. They can be no better in 2 weeks, but they're not going to get worse progressively over 2 weeks. That's not ischemic. So if you're ever worrying about this, see them back in 2 weeks and see how they're doing. And I told you 90 days, 3 months, I can tell you ischemic vascular palsies are significantly better in 6 weeks. The patient feels a difference, you'll see a difference. So with that, may all your palsies be isolated, live long and prosper.
Joe, within the questions here, one of our attendees asked, what would be a good resource to learn more?
What would be a good resource to learn more? There's a couple good resources, a couple actually great resources. There is a textbook on neuro-ophthalmology by 2 friends of ours, Doctors Nancy Newman and Valerie Busse, B-I-O-U-S-S-E, Nancy Newman and Valerie Busse. They are 2 of the most prominent people in neuro-ophthalmology. They've written a fantastic text. The other is a YouTube channel by Dr. Andy Lee. So just go to YouTube, Andy Lee. He works at Whiteboard. He is phenomenally good. He will have lessons anywhere from 3 minutes to maybe at most 8 minutes. And he'll put things over on a whiteboard. They're easy to listen to. He's got so many, I can't even begin to tell you. Very easy. So you got a text and you have a YouTube channel, just Dr. Andy Lee, neuro-ophthalmology, and you'll find it.
Yeah, those are great resources. I know both of those. Joe's introduced me to those docs, and just phenomenal, and really respect and love optometry. So those are great resources to put out there. And Joe, you have no financial interest in any of that, correct?
No, I do not. In fact, I get no royalties when people complain of double vision.
There you go. We have a doctor commented, had a 15-year-old patient dove headfirst into the Potomac River, hit a tree and then some rocks. The tree saved him, looks like a 6th nerve palsy, recovered after 3 months, kept asking if he could get a driver's permit. I think that's just more or less a comment.
Well, if he drove headfirst into the Potomac River, I'd be cautious about giving him a driver's license, because he may not be making the best life decisions there. But otherwise, he should be able to get it. There's nothing he can't do. And sometimes these traumatic ones can take up to a year.
Another doc is making a comment, or it's the same doc, but just another comment. To take photos in the 9 positions of gaze, I recommend an app called 9Gaze, and this doc has no financial interest, and neither do Joe or I. So thank you for that recommendation. You're getting a comment, Joe. Your odes are always a hit, so love your odes. So I think that's mainly the comments. Joe, I'm going to do one housekeeping here. Do you have any final thoughts, or would you like me to do the housekeeping?
Well, no, my final thoughts are thank you for attending. I'm sorry we had a few technical difficulties. Something didn't pop up that should have popped up, and it took me a minute or two to get going. But we enjoy doing this. We know these are special times, and hopefully this is helping people out. If you don't need the CE or you can't obtain CE credit, we do welcome people to attend and just listen and learn. I'm happy to invite my former students who are in practice, and my former students who are still at Nova. Like I say, it's almost like I'm still your professor, and it's almost like I never left.
Yeah, we had quite a few people that just wanted to listen tonight and not have credit. So thanks for those who did that. And Joe, thanks for passing on that knowledge. Vanessa, our conference coordinator, again, will send out this information to ARBO. It takes us about a day or two to turn it around. Once ARBO receives it, it's taking about a week with all the webinars. So please watch your ARBO in about a week. If something doesn't seem right after a week, please reach out to us and we'll have Vanessa check that all out for us. Vanessa will also send you a certificate of attendance for tonight. So 2 things will happen. Again, up to ARBO with the OE tracker number, and you will get a certificate of attendance, because I know not all states require the COPE credit, but this is COPE approved. You are going to receive an email probably now or within the next few minutes. It's about have it launched to go out in about an hour after the webinar. It does have a survey in it, and we would like for you to fill that survey out, because that's part of the regulatory board process. So with that being said, this is recorded. You will get a replay tomorrow. However, the replays do time out. You will need your unique password, but within the next 3 or 4 days, I will get this uploaded to our YouTube channel. It's very simple. Optometric Education Consultants. There's already other webinars on there right now. I'll thank everyone for attending tonight. Joe, it was your presentation. Please close it.
All right. Very much appreciate you coming. Stay safe. Eventually, we're going to get through this, hopefully sooner rather than later, and we'll get to see people face to face and really interact. So thank you very much. Be safe and be healthy and prosper.
You guys are going to log out.